three dynamic speakers who are going to talk to us about the transition from prison to the community. First, I would like to welcome you to the JOAG USPHS COF COOP Speaker Series. We're discussing prison health. Nationwide, nearly 700,000 people are released from prisons annually. Best estimates tells us that 30 to 40% suffer from chronic diseases such as hypertension, diabetes, and COPD. More than half have a substance abuse disorder, and 20% have mental illness. Formerly incarcerated persons encounter numerous barriers in trying to access services. The Transition Clinic Network has created a successful model utilizing community health workers with a personal history of incarceration to assist those releasing from prison and connecting with needed services in a timely manner post-release. North Carolina is in the process of adapting this model with the additional challenge of being in a non-Medicaid expansion state. Additionally, over the past few decades, there has been a striking transition in the setting where many people receive mental health services. While in the past, most received treatment in a hospital, now it is estimated there's 10 times more mentally ill people in jails and prisons than in psychiatric hospitals. As a consequence of this marked change, correctional facilities are now challenged with providing evidence-based psychiatric care to these patients. This presentation will focus on the practical steps that we have begun in the state of North Carolina, and these initiatives have both improved the quality of care, including the reduction of violence, and were also cost-effective. Our first speaker will be Dr. Paula Smith. She served as the Chief of Health Services Medical Director for the North Carolina Department of Public Safety from March 2001 through 2018. Please welcome Dr. Smith.
Good afternoon. Thank you so much, Camille. I'm delighted to be here and certainly excited to be on a panel with my dear colleagues here that I've had an opportunity to work with over the last few years. What I'd like to do this afternoon is basically give you an overview of the medical services in the Department of Public Safety or in the prison system here in North Carolina. I'd hope that the new medical director, Dr. Anita Wilson, would have been able to join us, but she had a meeting. She's only been in the position since June, so my position was vacant from January to June. So not a lot of changes have taken place just yet. As of yesterday, the population in North Carolina was 37,102. That represented just over 34,000 males and 3,000 females. Unfortunately, North Carolina, as small as we are as a state, we have the 13th highest population, prison population in this nation. Our prisoners are housed in 55 sites across the state. I tell people we can house you from the mountains to the coast. Unfortunately, I couldn't get the map that I used to have access to. I could not get that map to show you where those prisons are located, but trust me, they're all across the state. And then we have 2 confinement centers that are for parole violators. Our population has actually decreased by 3,000 since 2011. Probably one of my toughest years in the prison system was when we had over 40,000 inmates spread out. And that is a huge issue for the medical staff in our system because of the widespread number of prisons. However, there has been a 14% reduction in prison returns over a 3-year period. That has been noted. So fewer people are coming back to prison. They're leaving and more are staying out, which is a good thing. As far as the entrance and exits, last year, we always said it's like a revolving door. And you can see that the numbers here are reflective of that. We had 25,000 entries. I knew someone would want to know what the most common crimes were. Drug-related crimes are the #1 reason why people in North Carolina come to prison. The 6th one was DWI. Murder was way down the list with less than 1% of people coming to prison. You know, that's all we see on the news is about the murders, but that really is not a leading cause for prison entries. And then we had just over 25,000 exits. As people exit the system, we have a transition type program, mainly involving the custody case managers with home planning. Fortunately, our social workers are now working more closely with them to make sure people who may have health issues or mental health issues, they're at least leaving with a plan. We'll talk a little bit about the difficulty sometimes of carrying out that plan. But people are receiving education and there's some tracking. 12 of the 55 prisons that I mentioned just a few minutes ago are being converted to transition centers where people will actually go to those prisons to be released. Right now, people released from 55 sites across the state, but they're going to work to try and get people close to the area where they're going to be living when they leave prison. So we think that that's a very good plan. As far as the population by age groups, we have over 5,000 inmates that are between 70 to 92. And those of you that work in the prison system know that the age in prison is equivalent to 10 years on the outside, an additional 10 years. So someone in prison who is 70 years old is equivalent to an 80-year-old on the outside. You see the numbers, our highest number of prisoners, I guess, is between the 40 to 49 age group. The oldest male is 92 years old, and the oldest female is 85. And we have 42 men in our system that are greater than 80 years old and 5 women. So one of the things the public doesn't seem to have a grasp of is that we're dealing with the same types of chronic illnesses that my colleagues on the outside are dealing with. The cardiovascular disease, the diabetes, the cancer. Often we would say we're running a cancer service because there are so many cancer cases at our central prison. There are a lot of challenges to the provision of health care in the prison system. I've already mentioned the size of our system. Structured sentencing has caused us to really have to deal with these people staying much longer, aging, and us having to take care of these problems. The cost of health care is going up. It costs over $5,000 per inmate per year in our system to manage the care for an individual. The long-term care issues, currently there's a long-term care facility being built or renovated on the campus of Central Prison Hospital. It will be filled as soon as it's completed. We only got funding for 48 beds. We probably have at least 120 people that could be in a long-term care type facility today. And then the chronic illnesses that we'll talk about and how we manage those. This just shows you our mission and the goals. Our mission is to provide access to quality, cost-effective health care that is rendered by competent healthcare professionals. A lot of people think the people who work in the prison system, they can't work anywhere else. We have really made it our goal in North Carolina to really get quality providers. So we're very pleased with how that has been done in the past and know that it will continue. And I think looking at the goals, we have to uphold the mission of the department. We as healthcare people sometimes can be a little tunnel vision. So I used to tell my team, custody rules. There's nothing that the medical folks in prison can do without the custody people actually agreeing to be a part of that. You can't move an inmate, you can't provide the care, you've got to have custody involvement. So we've got to remember that the real reason for prisons is to protect the public, not to provide health care. Health care is just one small piece. And that was difficult for a lot of us to really begin to understand. But one thing that has happened in this state is that I believe our custody colleagues have started to realize how important the health care issues are in the system. They tell me if people don't get health care and don't get the right food, that's what leads to most uprisings in the prison system. I wanted to make sure that I stress the second goal. We pride ourselves at looking at ourselves as public health stations. I used to tell friends in the community, I practice public health behind the walls because so many of these people had the same type of issues that I dealt with when I worked at Wake County's health department for 7 years. And as you already saw, 25,000 of these folks are coming back to be our neighbors. And we want our neighbors to be healthy. So we pride ourselves on trying to make sure that that's done. As far as how care is provided, we have primary care services at every prison across the state. Some of those may have a provider on site every day, and we may have nursing services from anywhere from 8 hours per day, weekly, to 24 hours every day of the week. That's based on the number of inmates that may be housed at a particular prison and the level of acuity of those inmates. That's the amount of care that an inmate may be needing. If they are chronically ill and unstable, they're usually housed at a prison that offers 24-hour nursing services. I mentioned that the primary care services, we may have a provider at a site every day, but most of the providers move around and cover several prisons within a geographic area. If inmates need specialty care, the primary care provider will determine that specialty care is needed. They do a referral that comes to the central office, the case is reviewed, and a determination is made if we're going to be able to send this person out or if we should try and manage their care internally a little bit longer. Currently, we track these chronic illnesses: diabetes, cardiovascular disease, pulmonary disease, seizures, and we have a big lump of other. There are a lot of chronic diseases that we really don't track, where we have a chronic disease nurse actually following people. But for the top 4 there, we do have a chronic disease nurse who may be stationed at a given prison or covering a regional area who will help with the management of the care of inmates with those illnesses. One of the best programs I think we have in the prison system is our infectious disease services. We have case managers. These are nurse clinicians who actually follow all of our inmates who may have hepatitis C or HIV or AIDS. So that is a very good program. We worked with UNC for well over 20 years in developing a lot of that programming. So the inmates are tracked inside and then connected with UNC-related HIV clinics and some of the hepatology services actually when they leave prisons. They leave with an appointment. And I think that that is a very, very important piece that really needs to be expanded, probably for all chronic illnesses and for mental health across the state, if we're going to make a difference. Camille mentioned that about 30% of inmates have chronic illnesses in prison. Our data shows that. We've been able to have our IT folks to pull some data that we're now sharing with Dr. Ashkin and others as we're starting to work with folks as they're moving outside of the system. The count for 2017 was about 9,000, just over 9,000 inmates with those top 4 chronic illnesses that we looked at. And then we had about 1,200 HIV, AIDS, and hepatitis C, which came out to about 11,000 out of 37,000, which comes out to about that 30% that you mentioned. Then I extrapolated a little bit further. We had 26,000 people leaving, an estimate of that, and you say 30% of them are leaving with chronic illnesses. We have about 7,800 people who are leaving the system on a regular each year with some type of chronic illness. I just threw this little slide in here. Living with a chronic illness or disease is hard. Dealing with people who don't understand or who are not caring is even harder. So, you know, the inmates already have many, many issues that probably are not related to their healthcare conditions. So they're already struggling. And then when you throw the chronic illness on top of that, or mental illness on top of that, you really have a tough problem. I wish I could say that everybody that works in the prison system cares, but I'm sure you have folks that work with you that don't care quite as much as you do, or quite as much as you would like for them to, but it's really difficult when you're running into somebody that doesn't care, because they already have a stigma about inmates. And I always try to tell people, we are not here to be judge and jury. We are here to provide what is needed. And I've been quoted in the newspaper a number of times with my quote, we provide necessities, not niceties. So if you came with a lipoma, 9 times out of 10, you're gonna leave with a lipoma. If you came in here and developed cancer, we're gonna take care of your cancer or any other type of chronic illness that mandates that we provide care. I had the opportunity probably about 7 years ago. I was being drilled by the legislature. Why are you spending so much money and why are you treating all these people? What kind of cancer drugs do you people use over there? And I had to let this nice senator know that I could not treat cancer with herbal medications. A lot of people think that the standard of care that's provided within the walls should be less than what is done outside. Our licensure for providers are maintained by the same folks that maintain all my colleagues who work outside the system. So we're going to have to answer to that same medical board. And so we really have tried hard to make sure that we're practicing standard of care, community standard care. So how are we going to respond to all these folks coming out with chronic illnesses? We've got to develop some partnerships, as Dr. Ashkin will talk about. The bridging case management, I mentioned, we really need case managers for all the chronic illnesses and the mental health, so things are established for persons even before they leave the system. I know that there's a move afoot to try and get that in front of the legislature. We don't know what will happen, but we certainly hope that there will be some additional funding so that that can be done. That leads to financial issues. You know, how do you weigh trying to make sure the provision of care is appropriate for persons leaving the prison system when there are people down the street, your next door neighbor, who can't get health care. So there are a lot of things that the legislators have to weigh. The transitional planning, I think, will be very helpful in the transition sites that are being developed, the 12 sites across the state. We have pushed for there to be a healthcare component at the transitional housing centers, where people will be taught more about their chronic illnesses, how to manage their illnesses, and accessing care when they leave. We gotta get the right, committed people at the table. I think today is a great start. We've started some things even before I left the system, and I'm happy to say that those things are continuing and are improving. Those are all the slides that I had just to give you a brief overview of our system. I'll be happy to take questions after we all finish if you have questions about our system. Thank you very much.
Our next speaker is Dr. Ashkin. He has an extensive history in residency in family and community medicine. He is the current professor of family medicine at the University of North Carolina at Chapel Hill. He's the site director of the underserved track in the family medicine residency program at UNC. And what he's here to talk to us about is the program that he founded in 2017, which is the North Carolina Formerly Incarcerated Transition Program, that is used to address the absence of linkage of care for prisoners with chronic diseases, mental illnesses, and/or substance abuse.
It's great to be here talking with you all, and Dr. Smith did a great job of sort of laying out the issues that we're trying to face. As you guys probably know, the only time you have a constitutional right to health care is when you're incarcerated. Many of the people who are in prisons have not had health care prior to incarceration. There are a number of challenges people face when they come out, but one of the significant challenges is very low health literacy, a poor understanding of the disease that they may have been diagnosed while they're in prison. The timing in North Carolina to try and do something to help with the medical condition people suffer from was very much in line with the process that Dr. Smith was describing in creating these transition sites among prisons where there was going to be a focus on reentry and moving people back to their community a year or even more prior to release. And none of this is rocket science. These are all very basic ideas, but very effective. So you move someone back to their community. Let's say they're going to be at Orange Correctional before they're released back to Durham or Orange County. They have the opportunity to reestablish with family, with friends, and very importantly, with a reentry services that will be very valuable as people come out. So the state also invested in creating reentry councils, which are local groups where we bring together all the people focusing on reentry in the community, which can be with housing, job training, including vocational rehabilitation, mental health services. What has really been missing previously was a linkage to health care. But now what we're trying to do is bring that to the table as well. But unfortunately, with previously, when prisoners were released, they may or may not understand much about their disease. In general, they've had a month of medications at the time of release, but may not have understood the importance of taking those medications. And sadly, may not have understood or really necessarily had a lot of buy-in or self-activation in treating their medical problems. So we do know that a lot of people never received health care once they left the prison system. There are a number of illnesses, I think we all agree, that should very much be treated when people come out of incarceration. The work that Dr. Smith has done trying to understand what the incidence or the prevalence of those diseases are in North Carolina has been helpful. But when you include chronic disease like I have listed here, mental illness, and then substance use disorder, which we know affects 60 to maybe 70% of the prison population, the vast majority of people coming out of incarceration do need linkages to these services. And one very disturbing statistic, which was recently published, which Dr. Sheitman probably will talk about perhaps as well, this is a North Carolina data, that in the first 2 weeks post-release, they're 74 times more likely to die of heroin overdose than the general population. Okay, so what can we do to assist people coming out of incarceration? You have a lot of competing priorities when you're released. You need to find a place to live. You need to get a job. You need to reconnect with your family, with friends. And if you don't understand much about your health care, that may fall very low on the list of priorities. And unfortunately, we've seen over and over again people who are insulin-dependent diabetics who really don't understand much about their disease. They're released, they have syringes, a vial of insulin, and unfortunately don't know what to do with it, don't get follow-up care, and wind up with very severe complications of their illness. So about 10 years ago, a group in California and in Connecticut started to develop a model using community health workers who have a personal history themselves of incarceration, so they're able to make a connection with folks coming out of prison and gain trust and credibility in linking people to health care. In other parts of the country, these community health workers have been based out of federally qualified health centers or other safety net clinics to bring people into care. We have the advantage in North Carolina of having great partners with the prison system, with the community health centers, with departments of health, and also with our reentry councils that the state has already invested in. So actually we have Tori Green here, who's one of our community health workers in Durham, who is connected to all these different resources. So Tori has the advantage when he is connecting with folks, he already knows all the reentry resources in Durham, so he can help people not just get into needed health care, but also understand how they can get job training, how they can get their driver's license maybe reinstated, get into vocational training. So we have borrowed from this Transitions Clinic network, and we're part of that national group now. And in North Carolina, we have created a program we call the Formerly Incarcerated Transition Program, or FIT program. So we started in Durham County in February of 2017, in Orange County last year with a grant from the Duke Endowment, and then we now actually have a direct contract with DPS to hire more community health workers, and we're expanding in September into Wake and then into Mecklenburg and hopefully in other parts of the state. And our ideal setting is to do in-reach into the prison. So prior to release, that we work with folks, we are able to hopefully gain trust and be there for a warm handoff as people come out of incarceration with good contact information. It's another big challenge. And have an appointment ready to go and their health records, so we understand what their diseases have been, what they've been treated for, and then be able to link them to care. Now, Dr. Smith mentioned before that another large challenge in North Carolina is that we are a Medicaid non-expansion state. So unfortunately, if you, for instance, which 90% of the population in prison is male, so if you say you're a 35-year-old male, you will not qualify for any kind of health insurance in this state unless you are blind or disabled. And our goal, obviously, we don't want people to become blind or disabled. So we're hoping they'll never qualify. Sadly, folks with severe mental illness, that is something that will qualify for disability. So a number of folks with mental illness will be covered by Medicaid, but a lot of folks with hypertension, diabetes, kidney failure, other diseases don't qualify. And they're unfortunately have an income too low to even allow them to apply for Affordable Care Act insurance because of the way that law was initially written. So we have a very large challenge in helping people pay for their co-pays for these visits, even though it's only $25 or $25 at like Lincoln Community Health Center here in Durham, and then $4 to $10 per medication. That is unaffordable to almost all folks coming out of prison. So at the present, we have private funds that are going to help folks with those costs, but that is not sustainable in the long term. So we have a lot of interest in, from the state and from the Governor's Reentry Council on maybe how we can expand these services, how we can help people pay for their co-pays, and how we can put fit programs in other parts of the state. But there are also many communities that have very low resources, that don't have the resources, let's say, that Durham or Orange County have. And so how are we going to connect people to care in more rural parts of North Carolina is going to be another challenge we face. I know this is a problem across the country. Even trying to get someone an appointment at a community health center can be difficult if you don't have a direct connection. We've actually worked with the North Carolina Community Health Center Association, but then how do you get that person to go? And what we've learned in the Transition Clinic Network in the US is you really have to take the person to those first appointments. Hopefully they'll see a provider that they quickly establish trust with, get their medications, and then start the education process about their disease to get them on their way to health, while they're obviously dealing with everything else they have to confront. So I'd now like to turn over the microphone to Dr. Sheitman, who's going to talk about some of the mental health challenges people are facing.
Since about November 2016, or maybe 15, and this will be 3 years, whatever that comes out to, and I've been absolutely blown away by the number of mentally ill and substance abuse patients that I see on a regular basis there. I work on the restricted housing unit. That's the people who are all in sort of seclusion all the time. They get out maybe an hour or two a day. And it's just been an amazing eye-opener for me. And so it's really made me think about this. And so I don't have that much time, but I want to hit a few of the sort of lowlights about what goes on and what's kind of taken the correctional health care system kind of by surprise. I think it's taken us all a little bit by surprise what's happened. It's just taken me by surprise because I'm sure. Thank you. So getting right to it, when I got to the prison system, I was just blown away by how many mentally ill people there were. And if you look at this, is a kind of sort of sums up what's the kind of a tragedy really in our society about what's happened. So 3 lines. One represents the one on the bottom at the beginning, prisons and jails, the number of people locked up where per 100,000 adults. So in the sort of before 1940, it was roughly 200,000 or so people in prisons or jails. Then the next line up is people in mental hospitals, and then the combined total. So if you run the combined total across over time, it really hasn't changed all that much. But what's really shocking, what's happened is where these people are institutionalized. Where it used to be they're institutionalized in mental hospitals, the mental hospitals have dwindled away, and now these people are basically in jails and prisons. And it's really, in many ways, going back to what we had in like the 1850s or something, where people didn't recognize mental illness. That's absolutely terrible, and it's not a great place, and I think it's like one of these lose-lose situations. It's bad for the person, it's terrible for society, and but this sort of captures like why this has become a real issue in correctional health care. So another way to look at it, kind of, how did this happen? You know, where did this happen? So this is from the Treatment Advocacy Center, sort of looking at trends in state hospital beds from the 50s to 2016, and the number of beds per 100,000 population. Nobody really knows how many psychiatric beds you need, but the generally accepted guesstimate is about 50. So in 1955, that was like everybody when anything went into the state hospital. It was also before antipsychotic medication. So there was a huge number, probably way too much. But over time, the number of state hospital beds, if you look at 2005, it dwindled to 50,000, which is about 16.8 per 100,000. Again, you're trying to shoot for about 50. And then it just keeps rolling down. So in 2010, 43,000, 2016, just recently, 37,000. When you look even closer, what you find, half of the beds almost are filled by people who have criminal charges, forensic patients. So the number of civilly committed people in state hospital beds is about 6.2 per 100,000, and that's way less than what we think is needed. And the key about state hospitals, why state hospital makes a difference, because state hospital, in the real world, a lot of hospitals won't take people who are violent and have medical problems. So they just don't want to deal with them. So they ended up going to the state hospital. So what happens now is, without state hospital beds, people languish in the emergency departments. Eventually they get a little better, they get kicked out, back and forth, end up in jail, then in prison, and then we deal with it there. So it's really, I think that's the biggest thing. And we heard there's 55 prisons, and now there's 3 state hospitals in North Carolina, and we have 55 prisons. It's terrible. So what is the rates of mental illness in the incarcerated population? It's actually a tough question, and it's hard to really get at this. Because if you look at the SAMHSA, Substance Abuse Mental Health Service Administration, their prevalent 12-month prevalence of mental illness is about 18%, and about another 8% have substance abuse problems, so about a quarter of the population. So, and a lot of that's mostly anxiety and depression. If you look at state prisons, federal prisons, and local jails, it's much higher. Now, the exact numbers, it's really hard to know because a lot of this is done by surveys and it's kind of a mess. So it's a little bit sloppy, no one knows for sure, but we know for sure that the rates are just much, much higher. So it's not just also one of the criticisms, you can say, well, maybe this is the effect of incarcerating all people with drug problems, but actually when you look at, there's a lot of people with serious mental illness among them. So in North Carolina, we heard a little bit about that. It's hard to know, but the number that's thrown around for the seriously mentally ill population is 17%. If you look again at the SAMHSA definition of serious mental illness, it's about 4%. And serious mental illness is mostly psychotic disorders, but it doesn't have to be. It's people who are defined as really struggling. So if someone has bad obsessive compulsive disorder and checks the locks 400 times and can't leave the house and can't work, they would be considered seriously mentally ill. But the numbers on the national level, community is 4%. The rates that's thrown around is about 17%. So it's about 4 times higher. The substance abusing population, greater than 2/3, and I'm forever blown away by how many people use substances all the time. In terms of both together, which is also a big problem, I'm not sure, I haven't seen good data on that. But a lot of the seriously mentally ill people at the least will be telling you they smoke cannabis every single day. So practically speaking, like, why should we care? I say in practical, because I think in the world works better when there's practical implications to things. Just like pure altruism, everybody's got a lot of stuff. But practically, I think we've heard that there are 37,000 inmates in North Carolina prisons, but there are approximately 20,000 plus people, which I was surprised about, admitted and discharged back to the community each year. So there's really a lot of transition going back and forth. So it really behooves society to deal with people while they got them and can help them rather than play this game. And the people in prison, a lot of them have committed quite serious crimes. So it's really very surprising to me when I sit and listen to these social workers struggling to find placement for somebody who's got a severe mental illness, committed a very violent crime, best is ambivalent if they have a mental illness and need medication, and they're going to be going back to the community. And then, because the way the Medicaid rules are set up, like even if they had like an assertive community treatment team would follow them before or will follow them again, because nobody will pay the assertive community treatment team to deal with them before they leave. Basically, you give the person an appointment for 8 days later or 5 days later in the community with some medication, and they're going to probably stay at the shelter. To me, it seems totally goofy that we do this. I really don't get it, like why in the world we do this kind of stuff. But that's really what happens. And everybody's sort of trying, but it seems like, we got to do a better job of this because everybody would benefit. So what can we do? I think I'm going to give you, there's a lot, but there's evidence-based treatments that I was sort of struck with that we don't do routinely. And one of them is a medicine called clozapine. Clozapine is an atypical antipsychotic. It's used for treatment-resistant schizophrenia. So if you fail 2 trials of an antipsychotic, clozapine would be next up. Clozapine's a little bit of a pain in the neck because you got to draw blood every week. So we started using it a lot more in North Carolina. We've had some really good results. There's some evidence that it actually may have an effect for impulsive aggression, both self-injury and aggression toward others. So we were asked to present nationally to a larger audience, and then some people invited us to come out and talk to them. So we actually went out. One of the places said, could you please come out and discuss clozapine, because we see all the data. So we went out to Kansas, and we gave a presentation, real nice people, and we spoke to the psychiatry group, and I said, what do you guys think? And well, we're not going to use it. They were sort of ambivalent about it. And then I found out it's not even on the formulary. So like some states don't even have the medicine on the formulary, which is kind of interesting. And we're kind of doing a national survey now to see, is this just, Kansas, I suspect that it's not, and that it's much more pervasive. But, it's again, this thing that doesn't make any sense, because if you treat the person and, again, they'll get better, but also society will get better. We showed data that infractions went really way, way down by using clozapine. So a lot less assaults on custody staff, a lot less fire setting, a lot less flooding of cells. So it sort of made sense, and we just don't use it that much. But we're trying. Same thing with medication-assisted treatments. I won't get into sort of the details of it, but there are actually evidence-based treatments for opioid use and alcohol use, which we don't really routinely use. I mean, society doesn't routinely use them. But that's another thing, if you look, like why in the world would we not offer people medication-assisted treatments when they leave? Assuming, some won't want it, some aren't ready to quit. We get that. But for the people who are actually interested, why wouldn't you give them every single chance to succeed? Because, without getting your substance abuse problem under control, I think everything else just sort of falls apart. I think a lot of people think about, the social determinants of health and housing and all that stuff, and I'm completely in agreement with it. But without focusing on the substance abuse problem, it's just not going to work. So the community transitions, you heard, I think we're starting to do some of this. I suspect this is going on all over the place. A lot of people, see these people as a pain in the neck, and they could be a pain in the neck, and there's nothing wrong with seeing it as that, but it was still helpful for us to tighten up our discharge planning and see what in the world's going on. And then I think we all talk about, where's the data? It's really impossible to get any good data on this, and why. It's puzzling to me that this is a real problem. These are people, some of them commit quite serious crimes, and you think you discharge them out, you'd want to know, how did they do? And it's really hard to follow a lot of these folks, what is really going on. So I think there's a lot we can do. It's a tough, challenging population, but I think there's opportunities to really improve things. I would say there's so much misery in the world, but let's not create extra misery. And I think we can really do a much better job. And we're starting here in North Carolina. I think this is really a national problem. It's just not our problem. I sense it's everywhere. So thank you for the opportunity to speak. Appreciate it.
So we're going to open it up for questions. Does anyone have a question? Any questions?
Thank you, I appreciate it. My question is for the young lady. Can you tell me her name?
Smith.
Miss Smith. Dr. Smith or Miss Smith? Dr. Smith, thank you. When you say you work in the prison systems, are there any type of programs that is set up for re-entry? I heard you say a lot about the long-term care, are there any training programs where prisoners can become CNA or some type of certification while they're helping other prisoners to help them transition, you know, maybe some trade within the prison and then return in society with a trade up under their belt? So is there any type of trade skills that's set up within?
There are a number of trade skills set up, but not related to healthcare. We have not been able to get that approved here in North Carolina. There are a lot of rules. People would tell me stories about how the inmates used to assist in surgery and do all kinds of things many, many years ago. But a lot of the boards no longer will allow inmates or former inmates to be involved in that type of care. So we've not been able to get that established in North Carolina.
Can you tell us some of the trades that they do have?
I can speak only a little bit what I know about the program's custody side. Let's say someone was an electrician on the outside. They are coming in now, they actually do an assessment of what person's skills they have, what skills they may have had on the outside. And when they become eligible, usually once they reach minimal custody, they're given jobs that relate to those skills that they had. So there were people who worked in our building who were electricians on the outside, some of them who did roofing, all different types of jobs. And they do a great job in our system of trying to pair people up with the skills that they have, as well as help advance them in some of the classwork that they have.
Are there any classes within the system or any classes that teach about healthcare upon transitioning into the work?
One of the things that we're trying to work with the transition centers that are being established is to make sure that there will be a healthcare component. And Dr. Ashkin has worked hard on that and trying to make sure that becomes a part of the system. Our chronic disease nurses do some education, but not to the level that it's really needed. One of the models that we've talked about is something we used to do at Kaiser Permanente, where we would bring in 3 or 4 inmates with the same illness without divulging any confidentiality, just talking generalities, let's say about hypertension. What does it mean to have hypertension? What types of things do you need to do to monitor your health care? How do you take your medicines? To do those things generally, and then pull the inmate to the side to take their vitals and do any confidential talking that would need to be done. So I know that that's being looked at to try and do more of the education.
I say is that there's this Stanford model of living healthy classes, and we're actually going to pilot doing that at the Orange Correctional Site. We presented to a group of inmates last month, and they have interest in participating in these classes to hopefully improve health literacy, activation. The classes teach people how to talk to a healthcare provider as well, which is, I think, very important because unfortunately many people in prison have not had good experiences prior to being in prison with the healthcare system, and there's understandably for good reasons, unfortunately, a lot of mistrust, and so there's also courses not just on your disease, but also how to interface with the healthcare system.
So are there any programs that you would know of that teaches a prisoner that has diabetes how to give themselves self-injections? Are there any programs before they come into the public health, and we can, as public educators, can follow up with the teachers that's within the prison? Is there any type of programs like that, instead of them just crossing the line and being placed on someone else's caseload, and it takes time for me to learn about him, but it's vital for me to know everything about him, but I have 30 others as well.
Right.
So is it any way that we can connect, even going into the prison system itself, educating not only the prisoner, but the person who's going to follow up with that prisoner, so we can work in it holistically instead of him taking the steps by himself, being transferred to someone and someone and someone, which we work on it all together.
And I do believe that is the model we're trying to move toward. Now, just so you know, the inmates do give themselves their own insulin. They're taught how to do that. They're monitored when they're pulling their insulin into the syringe, and actually taught how to do it themselves. So they do that self-medication. But hopefully, and I know that some funding is available at present to try and get some persons that will be working within the walls to try and help with some of this transition as folks are coming out with all kinds of issues, to include the healthcare issues.
Right, and
Yeah.
it's just like you explained how you guys have educated one prisoner how to pull insulin. That sounds like a medical technician right there. So, you know, when he has the skills to help himself, he has skills to help others. And once he's released into society, and is on someone from FIT caseload, FIT can transfer him to, you know, a job that's being taught from the prison
Well, they can use
system
those
of North
skills.
Carolina. Exactly. So instead of a revolving door to come back in, it's a revolving door to keep going and keep pushing. So
Right.
that was my question. Thank you.
Hopefully we can get there.
Yes.
Does anyone else have a question?
So, Dr. Smith, you had talked briefly at the beginning a little bit about how you were trying to move inmates towards the end of their sentence to these local areas where they're releasing. Can you talk a little bit more about what those centers are going to look like? Is the custody level going to change? The custody level going to change for these guys once they get there so they are able to do more things in that space?
They will all be in minimal custody, and they can be moved to those sites, to the transition sites, as early as 24 months prior to their release. So there's to be job training, community involvement, reorientation with family. All of those types of things are to be set up through the case managers and the other folks working at those prisons. And we're trying to make sure that there is a nurse that is assigned to each of those sites. That is a big push, and I know that my former colleagues are all working on that. So trying to have a holistic approach for the persons who will be at those transition centers, so they can survive when they get on the outside without coming back.
Could you tell us what was the transition centers?
There are going to be 12 of the 55 prisons converted to transition centers, which will be basically sites where a person will go when they're about 24 months prior to their release, so that they can get the on-the-job training, lots of community involvement as they get ready to transition back into the community.
We have 5 minutes. Does anyone else have a question?
I'm sorry, I just have a question about the surveillance and follow-up data. Is there any national initiative to do that, or if there isn't, how does that actually work as far as surveillance?
So, yeah, I mean, Dr. Sheitman brought this up before. It's like, how do we not know?
Yeah.
I mean, it's just indicative of really, I think, the aggregation of our societal contract with folks who are incarcerated. Someone looked at the NIH budget from 2007, 2012, and how much was spent on anything related to studying the effects of incarceration on health, and it was 0.1% of the NIH budget. That's why we don't know. The Transition Clinic Network, which we're part of, actually, one of the things they've been successful at doing is with the network of clinics is aggregating that data to try and show what happens if you link people to care. And they have actually been able to, this was published in Health Affairs, which is a very reputable journal, a 50% reduction in emergency room utilization by enrolling people into the FIT program. We are trying to get enough numbers to demonstrate reductions in recidivism as well. That takes larger numbers, it's harder to do, but we are seeing a trend toward reductions in recidivism. And this has been demonstrated in Australia, where they have a national health plan and they're able to hold everything equal and just look at whether people got primary care medical services or not post-release, and folks that did had significant decreases in recidivism. So we are working in the state, actually, which it should be this way, the hoops to follow folks, because they are a vulnerable population, as prisoners are pretty significant, but we actually are going to be following outcomes of folks coming out of incarceration who are in the program to try and obviously demonstrate the benefits of being enrolled. But it's very difficult too in the state because there's no, if you're uninsured, you don't have a trail of charges that you can follow. Like if there's Medicaid or some other insurer, then there's a claims data trail that's created in an ER or a hospital. So it's another disadvantage we have is that when you're uninsured, you can't track people nearly as easily to look at utilization issues, and that's another handicap that we have.
I do HIV testing in Durham County Jail, and upon conversation with a couple of inmates in the past, very seldomly I've seen this happen, but I've just wondered what qualifies an inmate to be able to like be incarcerated and work at like a place like Panera or McDonald's, because I've had a couple of inmates that are able to do that. I was just wondering what qualifies them to be able to do that, and is that something that would be open to more inmates in the future?
One of the things that I learned working in prison is I needed to stay in my own lane. So I can't speak a lot to that, but I know that our programs folks do assessments, they do mental health assessments, risk assessments, and all types of testing and monitoring of folks before they're put out into the community to work. And you have to reach a certain custody level, I think it's minimal 3, before you're allowed to go out. Now, with some of the incidents that have recently occurred within the prison system, all of that is being reassessed. Because some of the upper management is very concerned about some of the types of folks that are in jobs outside of the system. So that is as much as I can really tell you about that.
So it's actually 1 o'clock. We're having a great discussion. Unfortunately, we're going to have to wrap up. Does any of the panel speakers have anything they would like to end the conversation on, the discussion? I want to say thank you for taking time out of your day to come sit and have a lunch and learn. And thank everyone for attending.